At The Nocturnist, we are careful to ensure that all stories comply with healthcare privacy laws. Details may have been changed to ensure patient confidentiality. All views expressed are those of the person speaking and not their employer.
It's hard to take care of patients whose lives are chaotic outside the hospital. They may have unstable housing or struggle with addiction, making it tough for them to take their medicines or show up to their appointments. How do doctors deal with this reality? I'm Emily Silverman, and this is The Nocturnists, stories about what it's like to work in medicine. In this episode, Hospitalist Meghan O'Brien talks about the challenges that came up when she took care of one particular patient who was homeless. Afterward, we talk about how we cope with the dysfunction of the healthcare system and how much emotional stamina is needed to take care of vulnerable patients. Have a listen to Meghan O'Brien.
So you know how sometimes in medicine you have these moments where real trumps your professionalism? I had one of these moments when I was a senior on the cardiology service, and it's an interesting service, or it's unique in that it pairs you one-on-one with an intern. But we had a pretty good team, and we were doing pretty well until we hit a blip in the road one day trying to discharge one of our homeless patients to respite, which is where they can go to get a roof over their head and a bed as they recuperate. And I'll call this patient Mr. Miles. And I knew Mr. Miles pretty well. He had tight narrowings in his coronary arteries, and his heart was sort of big and boggy from the drugs he did and the alcohol and some small heart attacks that he had had along the way. And so anytime he got extra fluid on his body, or anytime he did drugs that made his blood pressure go up, his heart would demand more oxygen than the blood squeaking through those little arteries could supply. And so I thought I knew him well, medically at least. We cared for him for the next few days, and every morning we would walk into his room and I would toss open the curtains and let the sun come pouring in and sort of cloyingly greet him like, "Good morning, time to wake up, get out of bed," sort of just trying to will the hope or fight or something back in him. And then we would do our thing, and as everyone would migrate out of his room, I would stick around and put the bed back down. And every morning as I did that, I said, "How about a shower today, Mr. Miles? I think it would really help you feel better." And I was serious about that, but he was also the sort of guy where the street had built up on him and really threatened to keep sort of distance between the people who cared for him and his humanity. And so I would ask him this every day, and he would always respond to me, if he responded at all, like, "No, I'm too tired today." And I didn't think it was just that he was sleepy. I had the sense that he was like that at the core sort of tired that happens when you have been sick for too long and you don't really want to keep going. And the social worker, who was awesome, I think she felt this way too. And so she had worked really hard to get him to respite, to get a reprieve from all of his illness. But when we got the call that the bed was ready, it was 1 p.m. and they said he needed to be out the door to be there at 2 p.m. And there was not a medicine reconciled and not a medicine filled and not a discharge summary done, and all these things needed to happen before he got there. So it was this massive Herculean effort on the part of the social worker and the nurses and the pharmacists and the medical students and the residents and the intern, and everyone worked together, and we did it, and we got him out the door. And we were gloating, triumphant, and high-fiving, and probably chest bumping. Maybe that's how it is in my memory. It was really, really triumphant. And we got a call that he didn't show up. And so I raised my hand in this really cartoonish, but totally genuine sort of, symbol of exasperation, and said some really colorful and unprofessional words to describe the feeling of being duped. and then I looked at to my right, and my medical student was right there witnessing this display. So I backpedaled and then offered something I wasn't really calling Mr. Miles names. I just it made me feel better to affirm to myself that, in all of our relationships, you have the right to be entitled to all of your feelings. And I felt the same was true in medicine. And so I wanted to reaffirm that for myself and for her. So a couple days later, I'm post a 28-hour call, and I am dressed on Halloween, and I have green paint on my face and this purple mask, and it's just a t-shirt that has a shell on it. So it's not my usual creative Halloween costume, but it was the best I could muster. I was at this Halloween party downtown. I decided that I had enough of this party and I was going to go home. But Uber was surge price, and I am morally opposed to paying $24 to ride a mile, so I decided to walk. And I'm walking through downtown San Francisco, up Market Street, and it was an interesting walk. Those things. And as I was contemplating, I looked to my right, and I didn't think twice before I marched right up to him and said, "Mr. Miles, what do you have to say for yourself?" And I was wagging my finger, dramatically and comically, and I've got green paint in my hair, and I'm peeling off my purple mask so we can see who it is, and my face is green, and he looks up at me and he recognizes me, and he extends his hand to take my wagging finger, and he says, "I didn't need it." And he doesn't let go of my hand for a while, and I tell him how full of it I think he is, that he didn't need it, and I asked him what he did with all the oxycodone we gave him. He looked really, really comfortable. And he said he just needed it for a little while, and then he was taking all of his medications. He still had them. He popped out his ankle, which was skinny, to show me, to prove it, that the water that he came in with on his lower extremities or his legs every time he'd come into the hospital the last 6 times was not there, and that he was peeing all the time over there, taking all his medications. And I told him I was glad that was the case. And then I told him, "I don't want to see you in the hospital again." And then, of course, I added, "But of course, if you need to come back, I would love to take care of you. And please look me up and I'll say what's up." And he's still holding my hand, and he gets this big grin. It widens a little bit more, and he says, "Thanks for stopping by, Doc." And he pulls my hand to his face, and he kissed the top of my hand, and smiles back at me. And I say, "That's Ninja Doc to you." And then we part ways. And I remember as I sort of faded back into just a tired Ninja Turtle walking down the street home, how much more beautiful our job is, and how much more connected we feel to ourselves and the people we take care of, if we let these moments of colorful realness shine through.
Hi, Megan. How are you today?
I'm doing okay.
Thank you very much for coming over to my home.
Thank you for the invitation.
One way that I like to start these interviews is to ask people to tell me a little bit about their journey to medicine.
Well, my journey to medicine, I like to say I took the long way to and through. So I wasn't pre-med undergrad because I looked around, and even though I was interested in medicine, when I looked around, everyone who was pre-med really focused on science to the exclusion, it seemed, of everything else. And that didn't seem like it resonated with me. I was interested in arts and dance and reading and writing, and science came easy to me in that I could sit my butt in a chair and study and learn it, and then do well on the tests by sort of conveying what I learned. And I did my undergrad at Brown, like you, and I was just surrounded by really smart people who were doing a lot of thinking and challenging of ideas, and it seemed to be a better use of my time to be in smaller classes where that dialogue and exchange was happening rather than being in large lecture halls. I studied American civilization instead, with the focus on race and ethnicity, and spent a lot of time thinking about power and privilege and race and gender as it relates to the United States specifically and the Americas more broadly, and focused on reading and writing and idea exchange. And around the time that I was thinking about whether or not I should go abroad to Argentina or take organic chemistry to do pre-med requirements, my friend's sister signed up for a post-baccalaureate pre-medical program. And so I realized there was this other pathway to medicine, and that if I was actually going to be a doctor, it would be a lifelong profession. And so if I still had that bug after I graduated undergrad, then I had this other avenue to access it. So I gave myself permission to abandon my pre-med ideas. I went abroad to Argentina. I studied dance pretty intensively in Mali and West Africa. And a lot of what I saw through my travels were sort of injustice and systems of oppression and power. And so when I got out of undergrad, I still had this interest in science and this yearning for a skill set. And I felt like medicine was a good way to address people as an individual and also have a platform to advocate for more systemic and structural change by virtue of the fact that society perceives status in the title of an MD, and that would empower my voice to advocate for my patients. And so sort of did a post-bac, went to medical school, and then ended up studying bioethics in medical school and working a lot with a clinic that served mostly undocumented immigrants from South and Central America called Puentes de Salud, and took a year off to do some of those projects while I was in medical school, and then I came for residency.
Wow. I would hire you. That's a really amazing story. And it seems like one of your strengths as a doctor is the fact that you recognize all of the different psychosocial forces that impact a human being's health and wellness. It's not just the disease, but it's also kind of who you are and where you grew up and what your background is that can impact your health outcomes. And you know, when people think about doctors, they think a lot about diagnosing and treating illness, but a big part of a doctor's job is actually care coordination. And you touch on that a little bit in your story. And I was wondering, for those of our listeners who aren't doctors, can you talk a little bit about that part of the job and what makes it so difficult?
Man, the first word that comes to mind is systems. It's very easy to feel like a lot of the systems that supposedly serve our patients, like health insurance, for example, are sort of set up to work against the goal of optimizing health. And so we have a lot of team members whose roles and responsibilities are primarily to navigate these systems. So we have case managers and social workers. We have outpatient case managers for patients who are very vulnerable. A lot of the social determinants of health that go into impacting our patients' care are really beyond the control of a physician, and so we depend really heavily on our other care team members. And oftentimes they, too, are unable to address these issues. So, for example, in San Francisco in particular, housing is a huge issue. And it's very hard for patients who have substance abuse problems and who have chronic diseases to manage those illnesses or to get clean or sober despite a desire when they don't have a stable place to lay their head or keep their medicines. And so we collaborate with our social work colleagues, but often the resources that they have are very limited, frustratingly so. And so that makes care coordination extra important, but also one of the major challenges that we face when serving vulnerable populations. One thing that is apparent in San Francisco relative to other states, so I did my medical training in Philadelphia, is that it seems to be much easier to get patients who are undocumented immigrants access to health care here in San Francisco by virtue of sort of the state and local services that are in place to support them. And so my sense of efficacy as a physician is empowered by virtue of the fact that patients can just access medications. That wasn't the case in Philadelphia, and so we had to do a lot of behind-the-scenes coordination and asking allies who are in various hospital systems to sort of do backdoor procedures or sort of take sort of these other alternative routes to getting patients medications, which is really disheartening and saddening that in the United States, where we spend so much money per capita, more than any other industrialized nation, on healthcare, that we still can't deliver care. We have poor outcomes, and we spend a lot of our time and energy using medicine and healthcare to address systems of inequity that we are underfunding and under addressing, like education, housing, food disparity, access to healthy foods and vegetables. Gastronomic justice, I think, is a term I've heard used for that. So,
what you're saying reminds me of a talk I recently heard by a geriatrician, which is a specialist who takes care of elderly patients. And he was saying that as we age, we become more and more disabled. And as a result, it becomes more and more difficult to live independently, which is really the most important thing. And that sometimes what his patients need are really, really simple things. For instance, a special type of hook that you can install on the wall that the patient can grab to pull themselves out of a chair. Because without that, they're not able to pull themselves out of a chair due to arthritis or some other health issue. And then he said that health insurance will not pay for that hook on the wall, that he can spend, hundreds of thousands of dollars on expensive MRIs and drugs and tests, but to get a wheelchair or a hook on the wall or other simple things like that the money can't go there. And it just seems a little out of whack to me. It's interesting how interlinked the systems are from the disease part, but how divorced they are when it comes to money and funding and the healthcare system. I wanted to transition a little bit into talking about Mr. Miles. Because in the case of Mr. Miles, in a way it was a success story. He needed a place to go to recover. And as you described so eloquently, there is this big team whose job it is to come up with a safe discharge plan. You and your intern and the case manager and the social worker. And you ended up getting him a bed at this place. But he didn't show up. And sometimes the issue is a lack of resources, but sometimes in the moment, it's actually an issue of getting the patient to buy into the plan as well. And what you can end up with is a situation where patients just keep on coming back into the hospital despite your best efforts to set them on a better track. And it can feel a little bit like a revolving door or like a Sisyphean process. How do you deal with that psychologically as a doctor?
It's really hard, and my resilience to dealing with that is directly related to, or I guess indirectly related to how tired I am. So, and how downtrodden I feel by working against systems that make the job difficult. So, the burden of documentation, for example, where you spend more time in front of a computer than in front of the patients. And when those computer systems malfunction and don't work smoothly, and you're being asked to be in 5 different places at once. So those sorts of things wear on your resilience. And I think increasingly we're recognizing that as burnout. But when I'm refreshed and I'm well rested and I have a greater sense of agency, I think just reminding myself of the fact that we see only a snapshot of people's lives, and lots of things go into the decisions that people make that we may label as quote unquote bad decisions. But we don't understand the complexity and the myriad of factors and trauma and access and competing needs and demands on that person's like emotional, financial, and physical resources. And so you can only do what you can do. I trained in a primary care program. And so being in this role now that I am as a hospitalist is an interesting one. And I find that my primary care training comes out a lot. And for me, I frame the work that I do as an opportunity to sort of harness the moment when a patient is so decompensated from a health standpoint that they have to be admitted to the hospital, and use that to sort of harness the hospitalized moment as a way to make an impact on their care, whether that's having a meaningful conversation and exploring some of these other factors that impact their health and connecting them to different care teams and really promoting their primary care doctor as their ally and reinforcing the importance of that. And whether it's finding small moments or small decisions to praise or allying with them about the difficulty of addiction. To the extent that I can find time in my day to carve that out, it allows me to sort of bolster my resilience for feeling not the most effective if they happen to come back for one of those reasons, quote, the revolving door. So I don't have great answers, but it's a work in progress.
noticed in your story is the way that you described Mr. Miles when he was in the hospital: tired, detached, disinterested. And the way that you describe him when you run into him on the street, he's sort of coy and friendly, maybe even a little flirtatious, for better or for worse. Tell me a little bit about that contrast, because you were talking about how there is a lot that go into people's decisions whether or not to show up at a place that the doctor would like them to show up, for example. What might go into somebody's choice to instead return to their place of comfort on the street, and how do you think that that might be reflected in the way that he seemed inside versus outside the hospital?
I would say, I think agency and sense of personal power goes into it. I think part of it, he was probably feeling good because he took the pain medicine that I discharged him with and was probably using it a little bit more generously than maybe he was perhaps getting in the hospital. And so maybe he was just physically feeling much better. But also maybe he felt empowered by being in his environment with his friends and in his community, which, I think we can create these narratives about what it means to be unhoused on the street and feel like that is a place that's devoid of richness. But I think that's probably because we're not looking for it, and maybe he has his own richness in his own community. He certainly seemed interested in these 3 women who were hanging out with him. So maybe it was about power and feeling good, and trying to escape the realities of his life, which was being confined to a really sick body, and prior to that being confined to a hospital bed inside. And maybe it was just a refreshing moment for him. I don't know.
Kind of makes you rethink the definition of healthy and happy in a way. Yeah. I think, again, it goes back to the idea that when people are in the hospital, we're only getting a snapshot, and, they're told they're interrupted every 4 to 6 to 8 hours. And we wake them up a bunch to take vital signs, and we wake them up to give them medications. We keep track of when they pee and when they poop and what their weight is. And it's a lot of monitoring, a lot of scrutiny. And I'm sure for some, being scrutinized in that way can be triggering, and just really feel like you're under a watchful eye. And I certainly know that I wouldn't like that. And I imagine it's nice to break free of that and sort of cast off the chains, and the immediate reward of that freedom probably exceeds the understanding of the consequences in that moment until they set in. And I'll actually tell you that I saw that patient again in the ED a couple weeks later, and I went up to him and said, "Hey, do you remember me?" And he was in a low moment, and he absolutely had no idea. I even said, "Hey, I was that Ninja Turtle doctor who went up to you. You remember me?" He had no idea who I was. He just wanted to know why no one was seeing him immediately, and if we weren't going to treat him. I wasn't taking care of him, but I was in the ED admitting another patient, but I recognized him. He wanted to know why no one had attended to him, and if we weren't going to take care of him, what he was doing there, and he was just going to leave. And I could see that he was struggling to breathe, and he was not in a great place. So I think we get only a sliver of people's life when they show up. Mm-hmm. It's really rough, and it's hard to know where the boundary is for what's possible medically.
Yeah, and it has to, and it has to be a partnership. And I think one of the things that you learn to do as a physician, and that I'm still working on, I think we all are, is striking the balance between holding someone accountable for the actions that contribute to their health outcomes and their decisions, and also recognizing that a lot of things go into that, and not pathologizing it always in a way that alienates them, but trying to build partnership around that. And it's a hard balance, and that too is a work in progress.
And that seems to be something that bleeds into politics a little bit too. How much of what happens to this person is a result of bad choices and individual responsibility, and how much of what happens to this person is directly linked to their upbringing, early life trauma, their circumstances, there is a tough tension there, I think.
Mm-hmm.
What about that moment when he kisses your hand and then you're walking away? What was going through your mind as you finished your walk home?
To be honest, I think I was like a little tipsy. Am I allowed to say that? And I thought, man, this is just so crazy. Medicine is so crazy that, there's all these intersecting, spheres, and it's just so real. It's so real all the time, and you get to be close to people and their vulnerabilities and their triumphs. And it's not the first time I've bumped into patients on the street or had to provide medical care in unusual settings. And it's just always so real and raw. And I really like that about the job. You don't have to be prim and proper and polished all the time. And I think being real and authentic, connects you to people. And I think that's mostly what the job is about.
Given your background in bioethics, social justice, thinking about race, thinking about gender, thinking about all these issues, you seem to be very in touch with these systems and these factors. And do you think other doctors could be better about that? And if so, how do we convey that?
I don't know. I work with a really wonderful group of colleagues who I think pays a lot of attention to these issues. I think there's many approaches to supporting providers being better about that. I think one is exposure across difference. It's really hard to have empathy for things that you don't understand. And I think one way to understand more is, to talk to people, to hear their stories, to read more like race theory, critical race theory, gender studies theory, to be exposed and humbled in ways that you can be when you are forced to be in another country and you don't speak the language and you rely on other people's generosity and kindness to help you, to experience personal struggles and difficulties, to know someone with addiction, to know people who struggle with these things over years so you can see the evolution. I think that garners compassion. And then I think also there's a critical piece, and I observe this in myself, which is making sure the providers aren't burnt out. It's a lot easier to maintain your compassion and your understanding, your empathy, and your stamina, really, because I think these issues require stamina to address. It's easier to maintain that if you feel like your needs are provided for. Because, when you work in residency, working 28 hours every 4 days and having 4 days off a month and only one at a time, never two consecutive, and having it be a random Tuesday when, your friends and family are otherwise occupied, it's really isolating. And then to be admitting a person who comes into the hospital, for example, every time they run out of their paycheck, and they'll stay to get medication for their alcohol withdrawal until their next paycheck clears, and then they leave against medical advice to go drink that whole paycheck until it runs out again. And to have that happen over and over and over again, it makes you wonder what impact you're having and what you're doing, and why you stayed awake for your 24th hour in a row to document an admission note for this person that may as well be a copy and paste from the admission note 1 month prior or 2 weeks prior or whatever. And it makes you wonder why what you're doing in that moment is important, and why you should be sacrificing sleep, because we know that not sleeping has health repercussions. Why you should be putting yourself literally in physical peril, not eating, not sleeping, not peeing, not, existing off of troughs of candy that are readily available. Why would you do that for someone who doesn't seem to be helping themselves? And it's easy to forget all the other things that go into addiction being an illness, like a real physiologically based illness. And sort of the trauma that probably set that person on that path of illness. So I think keeping providers, well supported and making sure that they have breaks and that their physical needs are met too is important to keeping a workforce that cares for vulnerable patients resilient and replete with the stamina needed to care for them.
I think that's a really good point. We talk a lot about combating burnout because if we have doctors who take care of themselves, they can take better care of their patients. But I think that's framed more on an individual scale. I will take better care of Mr. Jones if I am well rested. But framing it on a larger scale as resiliency or fighting burnout as a tool for advocacy and social justice, it isn't actually as big of a leap as it sounds. And I think that's something that we should be talking about more when we talk about burnout.
Yeah, definitely.
Well, thank you so much, Meghan, for coming in to talk about all these tough issues and shedding light, I think, on the complexity of it and how everything is intertwined. I think it was really educational.
Thank you for having me, and thank you for giving us a space to share our stories.
That was the very thoughtful Meghan O'Brien. Thanks for listening to The Nocturnists. If you like the show, please subscribe and share with your friends, family, and colleagues. And don't forget to leave us a rating on iTunes, because the more we get, the more people get to benefit from hearing our show. We're also really looking forward to our upcoming event on the theme of death and dying, produced in partnership with Reimagine on Friday, April 20th in San Francisco. Check out our website at www.thenocturnists.com for more details. And if you live in the New York area, keep your eyes peeled for news of an event sometime this fall. I want to thank executive producer Allie Block, podcast producer Marina Poole, Celine Ross, Kirk Clockey, Stephanie Muscat, Roshan Nebrajani, Yosef Monroe, and Blue Dot Sessions. Thanks for listening.